Good morning. To begin, please welcome back the President of the American Academy of Nursing, Bobby Berkowitz.
Welcome back. And it was a long lineup in the ladies' room. I don't know about the men's room. So this morning's second panel will focus on new models of quality and payment. And again, a reminder that you can submit questions in writing starting now, or you can also use your application. And we are also going to have an open mic toward the end of the session. So it's my pleasure to introduce our Planning Committee member, Tonda Hughes, who will introduce the members of the panel.
Hello, everyone. How you doing? This is the last, but certainly not least, of the plenaries for this year's policy conference. And I am very happy to be able to introduce the members of the panel today. I'm from the South, but I'm going to talk especially slow because one of the members is in the bathroom. I think Ed forgot to do his Kegel exercises. So I'll remind you that you can find the full bio sketches in your program book on pages 20 and 21. So if you will, and again, very slowly. Oh, he's here. Hi, Ed. Please join me now in welcoming our speakers, Tammy Peterman, Edward Salzberg, Eileen Sullivan-Marks, and the moderator of the panel, Paula Malone-Nuzzo.
Good morning. I want to welcome you to this panel on innovative models of quality and payment. We all recognize the role of quality and payment systems play in the provision of healthcare, and this panel is particularly relevant for us. Many of us live this every day. In recent years, we've been challenged with new models and programs that link quality and payment in some way. There's an alphabet soup out there of quality indicators that drive reimbursements to providers and hospitals. We already heard twice in the last 2 days about MACRA. And we just heard about the impending changes in the healthcare system payments. And unlike years past, many of these current programs involve publicly available data that can be used in decision-making by consumers. We have a stellar panel this morning who will discuss issues of quality and payment in healthcare. Each will come at these issues of innovations in quality and payment from a slightly different perspective, and I look forward to a robust discussion after their presentations. Each panelist will do a brief presentation, and then we'll have our conversation. And as was mentioned earlier by Bobby, please use your cards to send up questions. And our first panelist is Tammy.
Good morning. You know, I think that this is such a relevant topic, and as was just mentioned, each one of these will be a little different. And my story is a little bit about quality, actually a lot about quality. Karen Cox, a good friend and colleague, said, you know, this is a story that really needs to be shared, and it's a story of the transformation of our academic health system over time. And it's a really story focused on quality, but also patient satisfaction, and a little bit about people as well. And I think before we get into how it happened, I'd like to share just a brief history of really what happened at the University of Kansas Hospital a number of years ago. In the late 90s, our hospital was really on the brink of closure. And people didn't really know that, but if you looked at the data, you would clearly realize the organization was not going to be sustained for the future. Our patient satisfaction was some of the lowest in the country. Press Ganey didn't measure it past the 5th percentile. Our quality indicators, although people weren't measuring quality the same way at all, we knew that our risk-adjusted mortality was higher than it should have been and higher than expected. Our workforce of 2,200 employees was turning over at 33% a year, not sustainable for the future. And the healthcare market in Kansas City was growing, but the volume at our hospital was declining pretty substantially. We had 13,000 discharges, a 500-bed hospital with an average daily census of 140. That doesn't work very well either. And we were expected to lose a lot of money in the future. We were part of the state, the university system, and we had no real money to invest in the organization. And so in the late 90s, what do? Well, they brought a consultant in. That's what sometimes happens. They brought a consultant in who put together a pretty robust report. That report indicated there were a number of things we could do. One was close the hospital, the only academic teaching hospital in the state of Kansas. That's probably not a good idea. We could sell the hospital, maybe not the best idea. Another was to separate it and make it a public authority, which is what the legislature chose to do. And through legislative action in 1998, the hospital was separated, given its first checkbook of about $20 million, 20 days cash, 20 days operating cash, and 2,200 employees who were all leaving the security of state employment, and a legislature that really said, this is a Hail Mary, we hope it works, go forth and conquer. So let me tell you a little bit about what we did. And it was really a formula, and the formula was put together after we said, what is the core business? Well, the core business was taking great care of patients. So how do we do that? This is the formula. We didn't have the slide back then, but we have since put this together a number of years ago. It was really a focus on the patients from a quality perspective, but also a service perspective, and making sure we took good care of people, and that we had the very best people providing that care, support, and service. And we believed if we had those three elements in place, the growth and the financial stability would follow. Now, you think that's a simple formula, but it's a little counterintuitive. When you had no money and you weren't growing, you were losing volume. But we stuck to this formula, and for the last 18 years, it's been accurate at our place. So let me show you what our current experience looks like. Patient satisfaction was where we started. We said, we can rally the troops around patient satisfaction. We can do that pretty easily. So we finished the last fiscal year. You can see where we are at the 90th percentile. Actually, right now, we started the current fiscal year at the 90th percentile, and the new means and ranks just came out yesterday, so I think it maybe is at the 88th percentile right now, and the top decile performance with HCAHPS as well. From a quality perspective, we're tracking 1,000 quality metrics, just like every healthcare system in the country is, but we still believe our big dot is risk-adjusted mortality. And we compare ourselves to the academic health centers with Vizient, prior had been called UHC, and this is our mortality index. And for each month of the last 9.5 years, a mortality index has been better than expected, less than 1. We also then calculate the number of people who survived in our hospital who wouldn't have been, based upon the acuity and the complexity of the patient situation. The other, I think, really important metric is looking at people. So we had 33% turnover in 1998. Our hospital turnover is a little less than 12%, but nursing turnover is less than 8% right now. And I think that is a huge economic factor in any healthcare organization, to make sure that your turnover isn't higher than it should be. Okay, so what did we do? Well, we did a number of different things. We said there were dozens of tactics that we put in place, but one of the things we said is we needed to make sure that everyone knew what our data looked like. They needed to know what our patient satisfaction was. They needed to know what our mortality index was. They needed to know how many people were leaving our organization every year. So we shared the data. We were pretty transparent with that. Then we had to quickly follow that with a vision for the future. which we did. We put a number of training opportunities in place. We trained 20,000 people on customer service training. The executives went through 16 hours. All the employees went through 8. I don't know what that says, but the fact of the matter is that now all new employees still go through 8 hours of customer service training. We also could hold people accountable once training was done, and that was a really important element of our quality journey. We also knew that we had to share data regularly. We had to let them know how we were doing and do that in a timely fashion. Then we had to tell stories about what was happening in our place, the good and the bad, and we had to celebrate when things went well. The other thing we did was make sure that we set very clear expectations for a workforce. We now have a workforce of 10,000 individuals, 2,500 registered nurses. And we set expectations with all new employees, but every existing employee knows those expectations as well. We review 6 of them in orientation. One of those expectations is related to the fact that we all should be proud of where we work. I hope everyone's proud of where they work. We say be proud, but never satisfied. No, we can always do better, and we should do better. And one of those ways is our quest for zero harm. The slide that you see now is really looking at one element of our zero harm reduction strategy. We said we can't get to zero without having some incremental improvements year over year. We also changed the way we looked at data. We said we can get lulled into thinking we're okay if we look at rates. We have to look at raw numbers because we will miss the fact that over 100 people have catheter-associated urinary tract infections if we look at rates. So we look at raw numbers, and we look at raw numbers on a number of different quality metrics. And clearly you can see we've had a decline in each one of the last fiscal years. Our goal was 30% reduction from fiscal year 15 to 16, which we achieved. If we annualize where we are currently in fiscal year 17, that would be an over 45% reduction. Those are the things that I think not only will have an impact on patients, but will also have an impact on the economic issue of our healthcare environment. So one of the things that I wanted to finish with, I mentioned that storytelling is so very important. I was thinking about the importance of having information to share with all of our leadership team, and it's clearly about quality and it's about service, but at the end of the day, I think it's about people. So here's a story that I wanted to share right quick. We had a young woman in our hospital who came in and was diagnosed with a pretty devastating disease. She had a great supportive family. She was cared for in our hospital actually for quite a while. And as it continued to progress, her condition deteriorated. It was decided that this woman would need to go home, and she would go home on hospice to her community outside of Kansas City. And on the last day of her hospitalization, 2 nurses walked in the room, and they were not nurses on duty that day. They were nurses who had come in on their day off, and they had provided quality care and great service every day. But they came in for a different reason. The husband said, "What are y'all doing here? I know this isn't your day to work." And they said, "We're here to make this a better day." They came in and they had shampoo, and they had nail polish, and they had lotion, and they said, "This is a spa day for your wife." This is a woman they never knew because she was never able to communicate with them. But they knew that they could make life better for her and for her family. So they shampooed and styled her hair. They did a manicure. They made sure she was lotioned. They put a new outfit on her that her family had brought in. And they said, now she's ready to go home. So at her funeral service earlier this week, the husband got up and he told that story. And he said, angels came into my wife's room, and here's what they did. And he shared that story. And I think that happened because they were nurses. And I think it's because they can focus on quality, as they did, and they can focus on patient satisfaction. What they did was they focused on her. So as I look into the future, and we've been hearing about the future, I think the future of healthcare is bright because of people like that. Thank you. It was short.
Good morning. assuming my slides will come up. So I'm going to talk to you this morning about health workforce and how health workforce really fits into this picture. Great, thank you. So a few of the key messages that I want to try and transmit today. First, health workforce is really central to our efforts around transformation. It's central to high quality, cost-effective care. We talk, a lot of the discussion that we've had is around health workforce, but it's not focused on health workforce as sort of an area of study. But the goal of health workforce is really to make sure we have the right numbers and the right types with the right skills. So health workforce is really central to our efforts. Health workforce innovation is happening. It's a very exciting time. We know we've talked about pieces like the nurse practitioners, but other things are going on around health workforce innovation, which I think are going to be critical to our efforts to transform healthcare. The expanding roles and scope of practice for nurses is central to healthcare transformation, and in general, nurses have a very central role to play in our efforts at healthcare reform. Health workforce research, particularly research around scope of practice issues and using workers differently, is really central to our efforts to have an evidence-based delivery system. And then I want to urge the group to think about not only innovations for nursing, but innovations related to other health professionals and other health workers as being an important part of the delivery system. And then finally, a few words about the implications for nursing education. So briefly, what is health workforce planning? Health workforce planning is trying to promote a supply and distribution of well-qualified health workers to assure access to high-quality, effective, and efficient care. I will tell you it's extremely difficult to do health workforce planning. In America, we don't have a system that's organized around planning. We have many, many players. But it's really so critical, particularly now as we're talking about the transformation of healthcare, that if we're going to have the workforce we need 5 and 10 years down the road, we have to do the planning now. There are a variety of forces that are really driving this discussion. Most of these forces are well known, but I think it's important to look at them and consider what does it mean for the health workforce. First, clearly the population is growing and aging, and that's going to increase the need and demand for health services. Healthcare costs are unsustainable. We sometimes don't want to believe that, but the reality is there are limits to what we can invest in healthcare. We have an increasing number of chronically ill, and some of that reflects the successes of the healthcare system and the innovations that we put in place so that people are living longer with chronic illness. There's increasing complexity of interventions, meaning that there are more and more individual providers and practitioners serving each individual, particularly those with chronic illness. And then the goals, I think we're moving towards a point where we're talking more about not just keeping people alive, but about keeping them alive in better conditions with more meaningful lives and healthy aging. I was working on a project this summer with the WHO looking at aging and health and global aging, and it's really incredible how much of the world is aging. And if you think about what are the implications for the healthcare delivery system of an aging population, you recognize that we have to think differently about the health workforce. It's not just physicians, it's not just acute care interventions, but it really is prevention and coordination and really looking at how do we improve the quality of lives. And again, I think there are really some important workforce implications. And then the importance of social determinants of health. If health is more than just the intervention at the point of illness, then you realize that we need more workers than just physicians and hospitals and care in hospitals. So the implications for the health workforce, implications in general, there's clearly more pressure to do more with the workforce we have. And when I've thought about what's the likely outcome of having this increased demand and real need in America for additional health services at the same time that resources are limited, the answer is I think that we need to do things differently and we have to make sure that we are using the resources we have more effectively. I think teams and collaborative practice are an essential part of that. And I think we're going to need to think more about the integration of health and social services, again, if we're going to promote healthy aging and more meaningful lives. And we begin to look at the population focus, the population health as the focus. In terms of the health workforce, the delivery system transformation, which is really underway, significantly underway now, creates and helps support this pressure to do more with less. I want to be clear that I think the transformation, while it's being spurred on in part by public policies, is really a reflection of where we are overall in this nation of, again, needing more services but having limited resources. And so it's really the public policies combined with the private payers and the payer community and patients that are really promoting this transformation. The growing supply of NPs and PAs and other health professionals, I think, is enabling the transformation. If you don't change how you use your workers and the workers that you have, you're going to be extremely limited in the types of reform that you can do. When I was at HRSA, and I worked with our colleagues at CMMI and looked at the Healthcare Innovation Awards, of the first 107 awards, 96 had important aspects of using workers differently, either new workers or changes in what workers were doing. So I think there's a real incentive to make better use of the workers we have. That means teams and collaborative practice, new categories of workers, reassessing scope of practice and scope of work, and increased use of technology. This is a slide that I took off of the CMMI website. It changes regularly. It's a little overwhelming. Each dot represents a demonstration project that's being funded by the federal government around healthcare transformation, dozens of different programs, so many that some people are now saying we have too many. But the reality is we've really stimulated this incredible rethinking of how we can deliver services and how are we delivering services and how can we deliver them more effectively and efficiently. One of the cores of this change is I think we are really moving away from fee-for-service to value-based payment. And I think supportive payment policy is really essential to making the better use of the health workforce. Most of you know the many, many initiatives that are underway, ACOs, bundled payments, Medicare Advantage, and now we've added the MACRA, which we're all trying to understand, which have alternative payment systems. I really see the change happening across the country as we change the payment incentives. And when you talk to, whether it's hospitals or physician groups or others, because we're moving from a system of fee-for-service to capitation and the expectation towards population health, that's really opening up the opportunity to use our workers differently. In nursing, I think nurses in general are incredibly well situated to be the key personnel, the key health professional for this transformation of healthcare. Clearly, we're familiar with the efforts around advanced practice nurses, and I'll come back to that. I think the newer one is really the expanded roles for registered nurses in primary care and beyond. We should realize there are a set of barriers, real barriers to using workers more effectively or differently rather than in the past. Nurse practitioners, in my mind, are well through this process. The expanded use of registered nurses are really, I think, beginning to look at this process. So you need regulatory and legislative support, financing and reimbursement, organization and culture, because even if you change the regulations and the payment, if the delivery system, if the other practitioners are not used to using workers in new roles, you're going to find resistance. And we know there is professional opposition to expanded roles. Often the opposition is by a profession that has more education and prestige being resistant to having another profession with less education take on more responsibilities. And that works both ways for most professions. And then the need for credible research to document that, in fact, that the profession or the new roles or new uses of existing workers is in fact acceptable and leads to improved health. I think we're seeing a lot of research coming out now in terms of nurse practitioners that clearly the outcomes of care provided by nurse practitioners is equal to physicians when used correctly and when part of a team. And I think that documentation is there. It's not there yet on the use of RNs in advanced roles, in expanded roles, but I think we need to get the research, more research going. I wanted to put in this chart, because I try and track trends in graduates. This is data from AACN. And what it shows is that the number of new nurse practitioners completing programs, graduating, has been growing phenomenally fast. I mean, this, to me, the fact that the profession could grow so fast and all of their graduates are now being used within the system says that they're clearly meeting an important need. I will tell you that I do sometimes worry that this growth rate may lead to an overproduction. It's again, when we've tripled and more than tripled the number of new nurse practitioners graduating every year over the last 15 years, they're meeting an important need today. We do need to be cautious as we go further down the road. But again, I think this demonstrates that nurse practitioners are well accepted and clearly an important part of the transformation. Some of you may have seen the more recent, very recent report that came out of the Macy Foundation on registered nurses, partners in transforming primary care. I mean, I think this is the new thinking about where we're going. We've already made major progress in terms of nurse practitioners. Now we need to look at those 3 million nurses that are employed in America. How can we use them more effectively and expand their roles? I think folks are looking at, and some of this comes from the Macy report, the role of nurses in managing care of patients with chronic illness, being part of a complex care management team for patients with multiple diagnoses, coordinating care in the transitions between settings, and health coaches. I mean, nurses are just really well positioned and well prepared to play these important new roles. And if we transform healthcare and we've changed the payment system, and there are now now incentives to keep patients healthy, to keep them out of the hospital, then these are functions that the system has to be able to deliver. And again, nurses are very well situated to provide these services. Along with the changing role, it's important to say what is happening on the supply side. This data from NCSBN, the most recent data on on NCLEX exam takers, shows that the number of new BSNs is growing consistently and steadily over the past decade. The number of associate degree nurses appears to be leveling off or decreasing a little. I should note that while this slide shows that in terms of new entrants into the field, there are still more associate degree nurses than BSNs, but if you added to this 78,000 or so new BSNs, there are about 55,000 RN to BSN graduates this year, which means we're producing far more BSNs than we ever have in the past. This, I think, puts registered nurses in a position to assume responsibility for those expanded roles in the future. Again, one thought that if we're going to be open to expanded roles for nurses and nurse practitioners, we need to also be open to potential for expanded roles for other practitioners, other healthcare workers. And I found in the past it's sometimes hard for the nursing community. It's easier for the nursing community to see expanding roles above them, but a little bit harder to see expanding roles for health workers behind them. But I think we have to look at it, and it needs to be evidence-based, and we need to support additional research. These are categories of workers who are there in the delivery system, committed to care, committed to patients. We need to find how we can use them most effectively. There are some real challenges around doing health workforce research, particularly when it comes to research around using workers more differently and expanded scope of practice. Clearly challenges when you're dealing with human subjects, challenges of controlled studies, but we need to find ways that we can explore what the outcomes are of allowing different types of workers to expand their activities. Closing, I think it's important, the importance of preparing nurses for additional roles, the real responsibilities for the education system. This is going to be a challenge. We're still exploring and learning about what the roles will be for registered nurses in primary care and in chronic care. But the education system has to be right there with us as we explore these new roles, because if we don't prepare nurses for these new roles, I don't think we're going to be able to move it along as rapidly as need be. So challenge the education system. There's a real need to support health workforce research. And in general, I think there's just an incredible opportunity for the nursing community to be leaders in the transformation of healthcare for the population. Thank you very much.
Good afternoon. It's almost afternoon. So, I'm just trying to advance the slide to roll to the next slide. So we've been talking a lot about workforce, innovation. Oh, I see what happened. Could you go back to the title slide, please? Okay, it has to do with the template. So, not the title of my slide, but the statement above. Payment is the overt recognition by society of its overt recognition of our authority to practice. Back in the 1990s, when I was working for the American Nurses Association, or with the American Nurses Association, to represent nursing in Physician Payment Review Commission reports, as well as thinking about the beginning of the resource-based relative value scale and the fee-for-service payment system, I was a doctoral student, and I was thinking about, why is this so hard to get? If I have a plumber comes to the house and does some work and there was a service that was involved, then you pay the plumber. And so if a nurse practitioner is educated or a nurse is educated to do a certain thing, then we would get paid to do that. But at the time, as was alluded to in an earlier panel, if you were a primary care practitioner or a physician, you were paid less than a pulmonologist who did that same work. And we were trying to write all of that. So I struggled with, why was this so hard to explain to the group? Because when you would give a report at a commission, you would get, well, you're not as educated as a physician, you didn't spend as much time, but it really was at a time we were looking at the work. And I came up with this statement, that payment is the overt recognition by society, and it's the overt recognition. And that is so important to think about what we're talking about today. You get money for doing this thing, and they're saying you have the authority to do that thing. And in the 1990s, society wasn't sure that nurses was there to get overtly paid for that scope of practice authority. And that still is something that we have to remind ourselves today, that it's those principles that we're working on to move innovations and move the workforce to the next stage at a time now that we are in the Post-Affordable Care Act, where payment is now beginning to be based on value, where payment is increasingly global or bundled, and where payment is now society's overt recognition of our authority and our value in practice. And so we're quantifying the value, as you heard earlier today. So in our American Academy of Nursing, the Edge Runner Raise the Voice program has been very important. And I, along with Tony Villarreal and Donna Nikitas, co-chair the Raise the Voice, my role in that campaign is to work with the edge runners who are applying and to garner more ideas for innovation to move forward. And one of the things that we find when we are reviewing applications, and we review them 3 times a year, and we get 3 to 5 applications, I think we could get a lot more, is this idea that people don't know what to do when we ask for criteria on financial or clinical outcomes. So we heard clinical outcomes earlier today. People are more comfortable with that. Many of them come out of nurse design work. Many come forward with very good ideas and struggle with the financial outcomes, because we historically in nursing haven't been overtly recognized by payment for what we do. And so I encourage you to apply. And what we do in that, in the application process is we may get an application, it may be blank for financial outcomes, or it may be that they're pending, they're coming. We created an emerging edge runner status, but we also work with the applicants to help them understand better ways that they might explain financial outcomes that would be important to their work. And you heard some of the early edge runners today talk about their work, all of which have financial outcomes, some of which might relate to the direct patient care, might relate to hospital financial outcomes, or it might relate to the family's financial outcomes that were a part of that edge runner. And these are increasingly all going to be extremely important as we move through to the next stage of value-based payment, because we're telling those stories. So, with the edge runners, and I'm an edge runner for a program for all-inclusive care of elders, and I've been promoting those PACE programs for many years along with many others. We have moved along Roger's work of the five stages of innovation and design process. Many of you are out there designing new work. You're in the beginning stages of knowledge development, maybe randomized controlled trials, maybe qualitative work that you're doing, and you're in that early stage 1 and stage 2, which is knowledge development. The ideas are going off. I think this could be done better. I'm going to try this. Edge runners are in stage 3, 4, and 5, and that's where innovators are. So in stage 3 now, you've made a decision to go forward. You've crafted what it is, this innovation. You've worked with others, and you're implementing it. And confirmation is that you now have the clinical and the financial outcomes that are needed to really demonstrate it to policy work, to have capitalists pick up and support your work, and for it to be replicated and picked up. We had an edge runner breakfast this morning, and a number of our edge runners, 58 of whom we're proud to say, were there, and a number of them have been edge runners for a long period of time and are very excited about the continued distribution and disseminated of their work beyond their regions, across the country, where they are seeing their work picked up in other states, other Medicaid programs picking up their work, as well as people saying we're now able to bill for our work. One code was mentioned by Bern Melnick that she found a way to bill under CPT code 99214. Now, CPT code 99214 is the most often billed evaluation and management CPT code in the fee-for-service system. The other thing that we want to think about with CPT codes and our past work that we've done to highlight the value nurses have is that when we did the 5-year review of all of the CPT codes under the resource-based relative value work system, 75% of the sample used to establish the value for 99214 were nurse practitioners. 25% of that work value was physician work. So many of you may not know, but the little secret that some of the work, most of the work values in the E&M codes were established by NPs. And then I was able to show to the research committee at AMA that when you compared how nurse practitioners and physicians established work value, there was no significant difference. And so they were able to establish that into the system. That was a long time ago. All of this work now has to be done to being valued in very specific ways, and we are making nice progress. One of the earlier speakers on the panel was talking about thinking about how, from an economy perspective, we may go down 35% in healthcare economy. Struck a chord with me because the other day we at NYU had a retreat and had a speaker who's an expert in design, Dr. Jen Vandermeer, who is in the business school and the School of Art, doing design work, and she has done work with IDEO and other companies in the healthcare business, and said she's struck by how hard everyone in health works, by how hard nursing works. There's never a break, and for decades, there hasn't been any breaks in healthcare. It's been such a growth. She says, all the breakthroughs in design have come from failures. And that's exactly what we heard this morning, is that as we may see some trends and changes in how nurses may be realigned to do different work, that'll give us the opportunity to do new design. So tips for confirming our implementation that we've been encouraging our edge runners, but is true for all of us, are how do we extrapolate what we're learning through the Edge Runner program to policy? And policymakers, as we all know, are very interested in hearing the stories. And so, for example, the fact that with Angel Eyes, families at a distance are more likely to be able to continue to work, or they're less likely to have to borrow money for transportation, resonates with local politicians and policymakers. We need to, of course, engage in data. As I was giving the example of the work that we've done in the fee-for-service system, it's not quite former yet, but as it moves, it was the data that drove those changes and will continue to drive those changes. And the fact that we're edge runners, that we're edgy, that has real value across the country right now. The more that we can talk about this is an edge runner, a new idea, what we're doing is value, is very important and breakthrough. So thank you for any applications that you have for us from Edge Runner. You do not need to be a fellow to submit for an Edge Runner application, or you can invite someone you know with innovations. And then we'll hear more about that as we do our question and answer during the next 20 minutes or so. Thank you.
Thank you. Thank you to all three of you. I want to begin by following up on something that was mentioned by Ed, but also mentioned earlier, and that is the importance of teams in clinical practice and affecting quality and payment. I think there's a strong push for educational programs to teach their students in teams. We talked about that yesterday. But when they get into clinical practice, there are some disincentives to work in teams. Could you all talk about what kinds of incentives there might be in clinical practice settings that would support the development, support the work of teams, that could improve quality and enhance the healthcare delivery practices?
The only payment for teamwork in the Medicare system right now is in the PACE program, Programs for All-Inclusive Care of Elders, where it's a global payment and it's a requirement that you have an interdisciplinary team. So that's one of our Edge Runner programs. But it's clear when you look at why haven't PACE programs expanded to the level that they could. Don Berwick was challenging CMS to say, expand these programs. And one of the reasons when we looked at the barriers was the lack of understanding how to work together as a team. And so there are ways that one can do education in schools, whether it's with HRSA grants or with training and demonstration of how to work together from a team. It's a lifelong process, and it's very challenging you may learn how to work in a team for a few years and then need continued work. And so one of the challenges is out there is for that to be a technical assistance program within CMMI or CMS to do team training that gets proliferated everywhere.
I think that the change in payment policy, though, is providing incentives at the delivery system sites to use teams. Early this week, I visited a site in one of the nephrology demonstrations doing ESCOs, the accountable care for end-stage renal disease, and looked at the role of nurses and advanced practice nurses and the physicians working collaboratively, the physicians, the nurses, the advanced practice nurses, the technician, and there's a real incentive on this funding stream to get the team working effectively. And if you're going to be penalized if patients are going to be back in the hospital, you now have an incentive to say, what can we do to keep them out of the hospital? And I think when providers and organizations look at that, they say, well, what's the missing piece? Well, the missing piece is we need someone who's going to connect the patient between the settings. We need someone who's going to promote healthy behaviors. We need someone who's going to support the patient around their following their prescription, the medication regimens. And so nurses are really, again, I think in a good position. And so I'm finding they're really an important part of the team. And I'm hoping the financial incentives will make this happen.
I also think that in addition to financial incentives, and many healthcare organizations are putting those in place, whether it's medical director, hospital director partnerships, which really force the team to work together, or it's just making sure that the provider's work area is most efficient. That's an incentive. If we can work together, and we're doing this with some lean work, we're really applying the lean methodology in our healthcare organization, and that is really reducing waste in the healthcare environment, which is better for patients, it's better for our hospital staff, and it's better for any provider as well. So that's an incentive, and that work has to be done in a team. It doesn't happen if the team doesn't come together.
So several of our colleagues were very interested in your story about the quality journey. The big question from our audience is, how did you reduce turnover? What strategies do you use? Are they scalable? Can they be transferable? Can you share some more of that story?
Sure, and I've shared this a few places, and it's really not a 90-second quick thought, but I'll try and do it in 90 seconds. First of all, I think that early on we had to acknowledge in our organization the importance of nursing, and that needed to take place from the executive team. That wasn't just something at the front lines. The organization had to understand the value and the importance of nursing. We have a CEO who is very much an advocate for nurses throughout the organization. I think that we had to make life better for our nursing staff. We had to make sure that we had the right environment for people to work in. Nurses always come to work to try and do the very best work, but they also have to have the right resources. They have to have the best tools. They have to have great managers. They have to have support. All of those things, it didn't happen overnight. We started our nurse residency program. We were a beta site with the UHC program, as several other people I know in the audience were as well. That was really an important point for us. We are an accredited residency program. We hired 250 new graduate nurses this summer, and we've had 95% retention rate each year, their first year in practice. Those are a few little things I think that we put in place. There are a whole lot more, but I think it's the valuing and clearly our magnet journey. We started a magnet journey very early on. In 2002, we said we're going to become a magnet hospital. Actually, we didn't say that. We said we'll use magnet as a blueprint for us. And I told everyone, I said, I'm not sure we're going to apply, but we will be a better place because we're looking at this from a magnet perspective, and we became a magnet hospital. We just received our third designation.
Eileen, Ed, anything on nursing turnover that you'd like to share?
Well, I was thinking when in long-term care, which is going to increasingly be important, always has been important, but increasingly be visibly important with the value payment system, is that turnover in nursing homes for registered nurses, nursing aides, LPNs there is so just horribly high. In the PACE programs, the turnover of nurses, aides, and registered nurses is very low. We were able to retain 92% of our of our nursing aides and our staff in that long-term care program, because people loved working there, that it was a patient-centered program. We were able to pay them slightly better because of the global payment and how we set up the business systems to do that. But if you asked why people stayed, it was because they were doing the work that they really wanted to do with very challenging older adults and their families, but they felt like they were doing a service, but that their work was valued within the team.
Ed, this is related to your comment about the oversupply of nurse practitioners. As you can imagine, there's some angst about that. So can you speak a little bit more about that and your vision, given the fact that we have 20 million more people who are receiving healthcare delivery, and has that impacted at all the funding through HRSA?
First, I want to be clear, I'm not suggesting that we are at or near an oversupply of nurse practitioners. I'm really thinking if I look 5 and 10 years out at the incredible rate of growth, it causes me some concern. I have the same concerns around RNs, because we're now producing about 155,000 new RNs per year. I have the same concerns about physician assistants and other professions that grow very fast to meet a short-term need. So I'm not suggesting you need to worry now, but we need to be conscious, and we need to pay attention, pay attention to the marketplace and where nurse practitioners are going to work, what the demand is. Again, now they're filling a clear need, but you want to be conscious going forward. And so in general, the importance of tracking the marketplace in terms of the demand and the use of health professionals. Did that allay your concerns?
How about the HRSA funding? Do you know how we stand in terms of the projection for that funding pot?
No, I don't really know. I think HRSA has been very supportive historically of education for nurses and a variety of nurses, certainly increasing diversity. So I expect that nursing support will continue. My hope is, in general, that health profession support gets targeted to those areas of greatest need.
And colleges of nursing will always find ways to bring nurse practitioners in, not only to faculty, but you can always take postmasters or post-DNP certificates in some special new design area that we could develop, design thinking minors and special certificates. Yeah. So universities always find ways to helping out in those situations.
And right now, actually, the rapid increase in the number of nurse practitioners and registered nurses is really helping with the transformation, as I said. So I think it's good that we're producing as many as we are. I just really want to avoid what happened historically in the 80s and 90s, where we were producing, we ramped up the production of RNs and then reached a point really sort of hitting the wall, and jobs decreased and enrollment decreased. So you want to do a little bit more effective planning to make sure that we're not going to sort of hit the wall in 5 years from now.
I see our president's ready. One more? Okay, thank you. I'm really interested in the conversation around the use of registered nurses and expanding the role of registered nurses. We've all been through registered nurse programs. We have a lot of experience in that. What do you see as the barriers in expanding that role, and how do we get over those barriers?
That's a great question. Back to RBRVS, one of in the fee-for-service structure, there is also a value on overhead cost. And the overhead costs were mostly salary of supposedly an RN or a nurse or a medical assistant. And the American Nurses Association representative, Catherine Hanley, chaired the commission that established the overhead costs based on work and data from RNs in evaluation and management cost. And so we have data on what the costs are of RNs and what the work then of RNs, but of course they were counted in overhead. Now we need to take that work out from a payment structure to what is it that, that RNs have done. Claire Fagan wrote a paper, you know, back in the 80s that primary care is nurses' work, that nurses are the primary care providers. And she didn't mean just nurse practitioners, but all nurses in terms of prevention, delivery of services, et cetera. And then we lost the job opportunities for nurses in those areas. So I think we'll continue to go more into that area. Why couldn't nurses in primary care also be liaisons for the patient and family with physical therapy, with nutrition, with doing all of that work that needs to be coordinated?
You know, I think it's a great question. I think that, you know, looking at the list of barriers that I mentioned, you know, I think scope of practice is okay because some of the expanded roles for registered nurses is not going to be a state regulatory scope of practice issue. I think the payment systems with the capitation and global payment, there'll be payment there. I think cultural change is going to be important. Getting physicians and practices and patients to understand, and I think we're really close to that RNs can effectively perform in these expanded roles. And then the educational side, because I think we have to prepare nurses for primary care and for chronic care. And I'm not sure the best path to do that, whether it's an add-on or just tracks, or, you know, I leave that to the education community. And then finally, I think we need to build the evidence that RNs can work in expanded roles in primary care and in chronic care and long-term care. Again, I think there are a lot of forces moving in this direction, and it's a matter of pulling it together.
Did you want to share? No. Okay. This was a great panel. Thank you so much. I think it's very clear the important role nurses play in the future of healthcare delivery. You know, we've heard people say over and over again, this is our time, and you know, we need to be at the table and making important changes in issues around quality, affecting payment reform, and transforming healthcare. So thank you so much.
So I just wanted to mention that Ed had talked about the Macy Foundation's just hot off the press report on RNs in primary care. I just want to make sure you know that the Academy was a major collaborator and partner in that work. And in the policy dialogues this afternoon, there is a policy dialogue on that report itself and the recommendations and some of the follow-up. So if you're interested in that, attend that policy dialogue. So our media award. Several years ago, the Academy established a media award to recognize high-quality journalism that reports on health or healthcare with accurate, appropriate inclusion of nurses' contributions and perspectives. So I would like to thank Johnson & Johnson for their support of this year's Excellence in Media Award. This year, we had several stellar nominations proposed by a number of sources. One journalistic work in particular stood out for its excellence and its vivid depiction of the work of hospice nurses and their work with terminally ill patients. So I'm pleased to announce that this year's Media Award goes to Larissa McFarquhar for her two-part article, A Tender Hand in the Presence of Death, which appeared on the July 11th and 18th issues of the New Yorker magazine. Through compassionate and compelling storytelling, this article examines the daily work of a hospice nurse as she visits patients at their homes in several neighborhoods in South Brooklyn. The article not only beautifully depicts how intimately involved the nurses are in meeting the physical and psychological needs of patients and family members, but it also profiles the nurse as a fully formed human and the path she traveled to finding fulfillment in nursing. Larissa McFarquhar has been a staff writer at The New Yorker since 1998, and her book Strangers Drowning, Grappling with Impossible Idealism, Drastic Choices, and the Overpowering Urge to Help was published by Penguin Press in 2015. Unfortunately, Larissa was unable to join us in DC today, but we congratulate her on the superb writing that earned her the 2016 Johnson & Johnson Excellence in Media Award, and her article is on your tables. So please help me in absentia thanking her. So a special thank you to all of our panelists and guests this morning. I think it was an excellent series of dialogue and information and education, lots of ideas to take home. Now it's your lunch break with your colleagues and friends, but we have a full afternoon. So we look forward to our first session of our policy dialogues. Those begin promptly at 1:15. Then we have a healthy break. Then we have a second session of our policy dialogues at 3 p.m., and each time there are 3 concurrent dialogues for each session. So review the program, pick what you'd like to see. Those policy dialogues are a major part of our conference, and they're designed to provide you with an opportunity to dialogue with our panelists. So we're looking forward to your ideas and engagement. And then later this afternoon, those who are interested, please come back at 4:15 for our Finance Open Forum. This is a new feature that we're providing so you can share your thoughts and comments with the board and learn more about the Academy's budget. So thank you and enjoy your afternoon.
Cause you're a sky